evening, everyone, and welcome. Welcome to King's College London and to the Guy's campus. And I'm Professor Evelyn Welsh. I'm the Senior Vice President for Service, People and Planning. And it's my enormous pleasure to welcome you to this Sowerby lecture. First, some housekeeping. There are no fire alarms expected. So if one goes off, just follow me, please. And the lecture is being recorded. So if you have any issues with that, please do let us know. And then given the topic, if you have a mask and can wear a mask, we'd ask that you do wear a mask while seated, unless you are speaking. So thank you again. It's an enormous privilege to introduce this lecture, because I worked initially with the Professor of Philosophy, M.M. McCabe, and the new Sowerby Foundation on the development of this program, one that would meet Peter Sowerby's core belief that doctors need, above all, philosophy. There's no corollary as whether philosophy needs doctors, but I am sure that's something that we will discuss. Peter Sowerby was a Welsh GP who developed patient record software that was adopted by many of his fellow GPs, and he firmly believed that numbers and data needed to be treated with the humanity that came from philosophical thinking. So on behalf of King's and on a personal level, I'd like to thank the Sowerby Foundation for the support that it provides us to ensure that all our first-year MBBS students have the chance and the challenge to think philosophically. This evening, I'm going to first introduce Professor Elsaline Kingma in her inaugural role as the Sowerby Professor. Professor Kingma, whose work on the philosophy of pregnancy asks us to rethink the sense of self, has recently joined us from Southampton. She will introduce the Sowerby program before making the Sowerby Essay Prize Award, and that will be done to somebody who's collecting it online. We will then hear from our speaker. There'll be a chance for questions from the audience, both here and online, and then we will finish with a vote of thanks from Professor Richard Trambath, the Senior Vice President for Life Sciences and Health. So with that, may I pass over to our Professor Elsaline Kingma, who is in her inaugural presentation as the Sowerby Professor. Please welcome Professor Kingma.
Thank you very much, Evelyn. So I just wanted to briefly note something, tell you a bit about the Sowerby project. I think it is a wonderful vision that Peter Sowerby has endowed upon us at King's and upon me as the Sowerby chair to do work at the intersection of philosophy and medicine. So what work do we do, right? Well, we teach in a medical school, we teach in philosophy, and we hold events like the one today, which was preceded by an excellent workshop today and yesterday that some of you will have attended. Generally speaking, I want to promote all work that sits at the intersection of medicine and philosophy in all its forms. And I warmly encourage you to look us up, right? Google is your friend here. We have an online presence. We have a newsletter you can sign up to. We will be holding more events, and we have lots of information and recordings on our website. Yeah, I just want to warmly thank the Sowerby Foundation for generously funding us. Now, one thing we do is we hold an annual essay prize, and we did this year on the topic of today's lecture. And the winner of this essay prize, who I hope is joining us online and can maybe be brought up, is Piyush Pushkar, whose essay is entitled, "What are we talking about when we talk about protecting the NHS, and why does it matter?" Now, Piyush asks us to note how the government in the early pandemic response placed the NHS at the heart of the country's focus, right? We'll all remember the slogan, "Stay home, protect the NHS, save lives." Piyush, welcome. Thank you for joining us. Now, Piyush argues that this not only preyed upon symbolic moral meanings of the NHS, but also that by doing so, the government obscured its own state obligation towards us all via the provision of healthcare, and it particularly obscures and makes invisible ethical debates that should be had about the historical responsibility, which is borne by the state, for the current fragility, or at least the fragility of the NHS in the face of a pandemic response. So that is a very brief summary of Piyush's essay. I hope you agree with that brief summary. We selected your essay as the winner quite simply because it was well argued, it was well referenced, it was clear, it was interesting, and we as the judges learned from it. So please have a small round of applause for Piyush. Tell you who he is. So Piyush is an NHS doctor in Manchester, right? So a nice example of work at the intersection here, training to be a forensic psychiatrist. He has recently finished a PhD in social anthropology, which formed the basis for his essay. And his research is focused on political activists campaigning against cuts and privatization in the NHS. He also wants us to note, and I think this is really worth mentioning, that he's planning to donate the prize money to 2 organizations that campaign for better public services, called We Own It and Nurses United. So I think that is very generous. So thank you. And with that, I want to hand back to Evelyn for introducing our main speaker.
So our congratulations to Dr. Pushkar. And it's now my pleasure to introduce Professor Neil Ferguson, our speaker for this evening. He really classically needs no introduction. He is Professor of Mathematical Biology and Director of the MRC Centre for Global Infectious Disease Analysis and Vice Dean Academic Development in the Faculty of Medicine at Imperial College London. He's used, as many of you know, his skills to analyse a wide range of infectious diseases with major impacts within the UK and globally, from foot and mouth to bird and swine flu, Zika and dengue fever, and now, most recently, and perhaps most fundamentally, COVID-19. He has bravely faced the media, parliamentary subcommittees, and his own colleagues who've adopted, adapted, and challenged his and his team's modelling, making many of us commentators on social media into armchair epidemiologists, and perhaps most importantly, making all of us sit up and think through the implications of what mathematics can and cannot do for the way we think about our individual and collective futures. Can you please join me in welcoming Professor Neil Ferguson to deliver the annual Sowerby Lecture for 2021.
Thank you for that kind introduction. I'll just pour myself a glass of water first. Ironically enough, I came down with a cold last week, my first cold in, well, since the pandemic started. And I should say I've been multiply tested to make sure it wasn't COVID. So I am not a philosopher, I should say, but I will, and I can operate the slides, talk a little bit about the interface, let's say, between what I do, which is epidemiological analysis and modeling, and some things which I think are of interest to people of a philosophical bent. I'll just give my take on what do I mean by analysis and modeling to start with. I will weave in some of the research we've done during the pandemic, talk initially about those early findings around severity, transmissibility, which drove policy, and then go back to more reflections on the nature of modeling and the types of modeling we do in this sort of crisis. Some reflections on the science policy interface. I mean, this world has been quite an insular one in terms of, we mostly been focused on our own countries during this pandemic. My colleagues and myself have been advising governments across the world. And maybe I won't talk about that in much detail during the lecture, but we can maybe talk about the differences afterwards. Talk a little bit about the politics of science during the COVID pandemic and its politicization, and then talk, just to finish off, about where I think we are now in the pandemic, some of the work we've been doing this year on variants and vaccines. And if I have time, that's the final slide on thoughts as to lessons learned. This is my colleague, Stephen Riley, who is, I should say, now been seconded to the government. He's now director of the Joint Biosecurity Centre, but was very much active within our COVID response team at Imperial throughout most of the pandemic. Just to introduce, maybe going back etymologically to thinking about what analysis and modeling is. I mean, analysis is perhaps a little easier to talk about from the Greek, meaning unloosen or unloose, to decompose something into its constituent parts, as it were, to understand them better. Model, I looked for lots of definitions of model. Wikipedia actually has quite a good one, which isn't dependent on mathematics and informative representation of an object, person, or system. Cambridge University Dictionary had had many definitions, including fashion models, but let's stick to mathematical modeling here. Simple description of a system or process which can be used in calculations or predictions of what might happen. I should say equally important to those and underpinning all of what we do with mathematical modeling is the process of inference, really statistical inference I'm talking about here, namely using data to test different model formulations, to understand mechanisms, epidemiological, evolutionary mechanisms in some cases, and to draw conclusions from that. And so the sorts of things we do, and in my career I've done this many times, many different outbreaks, tends to be initially looking at early data to estimate key parameters of interest, epidemiological parameters like the incubation period, the generation time. How severe is this new virus? What's its lethality, and how does that vary between people with different characteristics? How transmissible is it? And then that can go into a more informed risk assessment, which can start informing a policy response. In retrospect as well, as interventions are rolled out, we can use epidemiological tools to analyze the impact of those interventions. Only a small portion of what we do, and it is a minority, you might call prospective modeling or transmission dynamic modeling, trying to project forward into the future. One might be, and I'll talk about it, a kind of controversial use of modeling in some quarters is counterfactual modeling. So modeling possible futures under possible intervention scenarios, saying these are the potential outcomes. The other is just, and I won't really talk about that here, is downright forecasting, as in weather forecasting. I like to think of modeling as really being quite a useful tool for knowledge synthesis as well, of pulling together the blue boxes here, I won't read them all, different data streams, which are of epidemiological relevance or relevance to control measures. And they can be not just the biology of the virus or the pathogen, but also around the nature of human society and contact patterns, demography, which is relevant to the epidemiology of that bug, to get out some key things, insight into mechanism being probably scientifically the most important. I've already mentioned estimating fundamental parameters, and then sometimes short-term predictions of the future, evaluation of potential intervention options. It's particularly difficult in an outbreak scenario or start of a pandemic. And so this is true of not just modeling, but all science in the pandemic, just because how limited data is to start with and the level of uncertainty. And yet we still need to inform policy, to inform fundamental decisions, whether it's about what interventions governments take or planning healthcare capacity, whatever it is, we need research to be timely. And in that context of very high levels of uncertainty. So it's a challenging environment to do real-time research. And that's why, at least in this country, and a lot of countries, more heads looking at the topic are better, having multiple views rather than just one. And whilst you aim for consensus in that, you try to understand the differences different groups come up with, true in virology, immunology, as it is in modeling. So unlike what you might have seen reported in the media, I mean, the models we've done at Imperial College have not been the sole things inputting into government policy. They've been one of several, sometimes 6 or 7 groups modeling, but even back in March of last year, there were multiple groups feeding into policy and to decisions which were made at that time. Let's talk about those early findings. The early questions, and again, these come up every time and time again with every outbreak. What's its true scale? We always know that surveillance at the start of an outbreak tends to miss the great majority of cases. It's biased towards severe cases, often takes a long time for testing capacity to come up. Governments don't always share information as readily as they might. Not sure if anybody wants to.
The online community is.
Yes, maybe you can. How fast is the virus spreading? And how much of a threat then does it pose? I mean, I can flip off this and mute people if you want. Okay. And then finally, what can we do about it? Go back. So taking the first stage, size of the outbreak in Wuhan, and this was when I started to get concerned about the outbreak, and it was around January 9th, 8th or 9th, that whilst at a time point when China was only reporting 41 cases, actually fewer than that, 26 to start with, a case popped up initially in Thailand, and then another case soon afterwards in Japan, and then a third case in Thailand. And that immediately rang alarm bells because, and this was a very simple calculation we did back then, you can look at the population size of Wuhan, and you know we had detailed data on flights in from every city in the world, and these things are recorded, and you can make an estimate of what's the chance that somebody who is not showing symptoms initially when they fly, what's the chance they might fly to an international destination like Thailand from a city like Wuhan, knowing how many people flew out of Wuhan every day prior to the pandemic. And we came up with the estimate roughly, with a lot of uncertainty, there was a 1 in 600 chance. And so for 3 cases to have been detected by the 16th of January in international destinations, even assuming the rest of the world had perfect surveillance, implied there had to be at least 1,800 cases or so, with a lot of uncertainty in that city. And so that immediately pointed towards human-to-human transmission as a driver of the outbreak. And rapidly, those case number estimates escalated into the tens of thousands and higher. And so these were, we quantified the uncertainty under a range of different scenarios, but we were coming up with numbers which were 20 times larger than those reported at the time from the city itself. And by 3rd of February, that estimate had gone up to 110,000 cases. The next thing to look at, given you're estimating the outbreak is of that size, remember this is at a time when human-to-human transmission hadn't been formally documented until late January. So it was still very uncertain in mid-January whether it was just all caused by that seafood market in Wuhan or was human-to-human transmission. But as soon as you get estimates of that size, it's much more likely to be human-to-human transmission. And then you want to estimate this thing called the reproduction number. Everybody now knows what the R number is. It's the number of secondary cases per primary case at some stage of the epidemic. Right at the beginning of an epidemic, it's called R0. And the important thing is it needs to be greater than 1 to have a self-sustaining, a growing epidemic, which causes exponential growth, as you see here. And so through 2 different methods, and I'm not going to go into methods today, we derived estimates based on very, very limited data. This was the first estimate of with a lot of uncertainty of the reproduction number in Wuhan being about 2.6, a range of 1.5 to 3.5. And then using actual case data from China by date of onset, this is the gray hashed out areas. The case numbers are dropping then because this is data as of January 29th and there's a reporting delay. You can see that clear signature of exponential growth, and the blue hashed thing on top is a real-time estimate of the reproduction number. It bounces up and down because that's lots of noise in the data. What did you know? But it ranges between, again, the same sort of range, 2 to 4 roughly. And then the most difficult thing we did in that early stage of the pandemic was try to come up with an estimate of severity, the infection fatality ratio proportion who will die from infection. And it's difficult to estimate for multiple reasons. First of all, there's biases in the fact that it takes people some time to die, 2 to 3 weeks. And so if you just divide cases, deaths by cases, you get a biased estimate. More importantly, there was an enormous bias towards detection of severe cases. Basically, as the UK did early in the pandemic, the only people being tested in Wuhan early on in China were people who were hospitalized and actually mostly had pneumonia. Mild cases were very rarely tested. And that made it difficult to estimate the true scale of the outbreak, the actual number infected, the bottom of this pyramid of infection, where we had very little indication. We got data from actually a source you might not imagine, but which proved very useful. There were repatriation flights from Wuhan to a number of Western countries of Westerners leaving the city after it locked down. And everybody on those flights was tested for infection. And some flights had found multiple people infected. And so that gives you a measure of infection prevalence at a point in time. If you make a very crude assumption that these people were mixing within the Wuhan population in general allows you to come up with an estimate of the number infected at a particular point in time. We knew numbers dying, and therefore we could start to come up with an infection fatality ratio estimate. There was quite a lot of statistical analysis behind those statements, but we came up with an estimate of 0.7% for China, which translates because of this very strong age dependence in death and the fact that the UK is a older population than China to 0.9% in the UK. And lots of people have done similar estimates since. This is just our most recent set comparing data from multiple countries now. And here now we're estimating number infected using serology surveys. But you see this very strong exponential growth. The bottom plot is on a log scale, exponential growth of the fatality risk with age. And so those quantities, the reproduction number, I should say in the background, we also knew something about serial interval generation time and the severity of this disease and knowledge that it was transmitting through the respiratory route starts to allow you to do a risk assessment of what will a large-scale epidemic of this virus look like, what sort of healthcare demand, because we also estimated, as well as just mortality, what will be the likely healthcare demand from the epidemic, and then start looking at policy options. And the challenge, of course, early on is we had no drugs or vaccines. We only had social distancing, case isolation, things like that, which we knew from the outset, from just seeing what was happening in China, would be immensely economically and socially costly. And so the key question that multiple countries around the world struggled with in February and then into March of last year was, do we follow China and lock down, suppress transmission? By suppress transmission, I mean adopt a strategy which drives that R number to below 1, so case numbers start declining. The big downside of that is that as soon as you lift interventions, case numbers bounce back up again. Or do you do what we've done in every other, frankly, pandemic, which has struck human populations, is not try to stop it in its tracks, but try to minimize the number of people dying, maybe try to shield the elderly, give people the best treatment we can. And I won't go into the details. In the UK, at least, I mean, there were 2 models used. One was the one we came up with and adapted in Imperial College. Another was Nick Davis's work with John Edmonds at London School, both coming to very similar conclusions and these conclusions don't actually depend on having a complex model, that the rate of growth of the pandemic, even being observed in the UK, together with the predicted severity, would mean that under any scenario, we couldn't come up with a way of mitigating the pandemic which wouldn't involve the NHS being overwhelmed. That was the primary conclusion. And we published later papers then extrapolating then to many other countries. The challenge, though, is those 2 different policy options have very different implications. If you're trying to mitigate what we've done in the past, then you time interventions. You still need interventions, but you time them around the peak of the pandemic. If you're going for suppression, a fundamentally different strategy, acting early is always beneficial. You have this exponentially growing epidemic. The sooner you lock down, the better. You drive infection numbers low, then you lift interventions, you let infection numbers go up again, and then you drive them down again. There's no additional cost to keeping infection numbers low rather than letting them high. And the challenge we faced back in March is just this doubling time. Let's say it's between 3 and 4 days. Infections are doubling that time, then every 4-day delay to locking down doubles the number of deaths you're going to see in that first wave. And so we've done counterfactual modeling, looking at what would have happened had we locked down a week earlier. We'd have only had 15,000 deaths in that first wave, as compared with 37,000, and a week later, it would have gone up to more than 100,000 deaths. The challenge has been, and the challenge which has been incredibly difficult for policymakers to really grapple with in any country, has been of adopting suppression as a measure, is this challenge of exponential growth, that the measure only works whilst it's in place. You're left at the end of it, if you've been successful, with nearly as many people susceptible to the disease as you had to start with, no real immunity in the population. So as soon as you lift measures, you have to bounce up. So all the way back in February of last year, we were saying, if you adopt this measure, you will have to lock down repeatedly. The only exit strategy eventually is vaccination. And of course, that's what was seen across Europe. It actually took longer than we anticipated. There was a delay from relaxing lockdown measures to seeing case numbers bounce up, because human population, rather traumatized human population around the world, were slow to go back to normal contact patterns or anything approaching it. But after time, that did happen, and then contacts went up to a level whereby the reproduction number, the R number, went above 1 again, and we saw rising case numbers. This is plotting mortality per million on a log scale across multiple European countries. We saw that autumn wave of rising mortality, and you could argue some countries did. If you look at some Scandinavian countries, acted very quickly then to suppress transmission, but many countries found it politically very difficult to do so. It was slow to act, as I said. And that's partly because back in February and March, everybody was very well aware of what was happening in China, of the risk from COVID. Nobody had actually experienced the impact of the social distancing policies. And by, I think, the autumn, people were much more aware of those economic and social costs. There was also a lot of noise in the popular discourse, much more skepticism around the scientific consensus from some quarters. There was some hope that test and trace, which we invested billions and billions of pounds in, would be sufficient to keep transmission down. And that meant, in the face of rising case numbers, and test and trace wasn't really enough, still governments around Europe, around the world, took an incremental approach and localized approach to trying to slow spread rather than stop it in its tracks. And that led to this large autumn wave. And most European countries, including the UK, have seen 2/3 of their deaths from October, November onwards. The actual first wave is only a small portion of the mortality seen in this pandemic, as shown below. So stepping back from the science now, let's just talk about types of modeling. And one of the main challenges of doing what we do, which is in terms of doing applied research, trying to inform policy, is this concept of counterfactuals and the level of uncertainty as well. So in some sense, there's quite safe, let's say, modeling and analysis done in most disciplines, which is a retrospective analysis of phenomena, of data, trying to understand, it's true in epidemiology as it is in physics, trying to understand patterns we see in nature, trends, come up with hypotheses, formulated as mathematical models, test those against data, estimate parameters. In epidemiology, we're also interested in, for instance, and clinical sciences generally, might be interested in assessing the impact of interventions. Gold standard there is clinical trials, but for social distancing measures, those are difficult to do, but we can still retrospectively, using observational data, try to understand the impacts they had. So Generally, this is less controversial. Some bits of it have been rather politicized in this epidemic. For instance, estimates of the infection fatality ratio, for instance, of the impact of interventions have in a small minority of scientific community been, and maybe a slightly larger minority of the public discourse become politicized, but generally there's quite a lot of consensus now around those sort of estimates. More controversial is kind of prospective modeling work. Short-term projections may be a little less though, but there's plenty of critiques of those. And I mean, a lot of work has gone into forecasting, but it's incredibly difficult to do reliable forecasting when you have constantly changing both policies, which you can't necessarily anticipate day to day, and population behavior, and lots of things we don't know about the virus. Risk assessment, I've already mentioned, can be controversial, but perhaps the most controversial one is counterfactual scenario modeling of interventions. And it's very easy to criticize because you sort of know you model a wide range of scenarios about how the pandemic might evolve under different assumptions of policy. But reality is never going to match one of those scenarios, and inevitably you have to make highly simplifying assumptions. Nevertheless, policymakers find it very valuable. We've done a lot of both, probably actually more of the left-hand side than the right-hand side, things like the estimates of severity, estimating the effect of non-pharmaceutical interventions, and then quite technical analyses of spread in individual communities, assessing the transmissibility of the alpha variant. And then, as I said, quite a lot of scenario modeling as well, starting with things like Report 9, though lots of work went into government before that, and then work extrapolating that to other countries, and then things, well, papers, scientific papers, which really span both. What they do is look back on work we'd already done for government and been putting in reports to SAGE month after month, but then took a backwards look at that and saw how we did. So a couple of papers there, paper, I'm very pleased, came out in the Lancet last week on the work we did on the roadmap out of lockdown and modeling the impact of vaccination. One thing we haven't really got, well, only slightly got into one of those papers, but to give you an example of the sorts of challenges we're talking about is back in October last year for SAGE, we and the other groups feeding in, modeling groups feeding into SAGE, were asked to look at the need for a second lockdown in October, November last year, and then look forward to the potential impact of, first of all, relaxing restrictions over Christmas, and would we need to lock down after Christmas? And so we did this, and what you see here is, without a January lockdown, but with a October or November lockdown on the left-hand side, and then with a January lockdown on the right-hand side. This was before the alpha variant. So even at that point, we were saying, in order to keep on top of this and not have another even worse wave than the first wave, we'd probably need two lockdowns. We'd need one as soon as possible, really, in the autumn, that most likely we would need one in January as well. Alpha made that far worse. Now, it's very easy to criticize this modeling because reality didn't turn out like any of these scenarios. Policies were put in place, the virus changed, but nevertheless, it was informative for policymakers to have a sense of the nonlinearity, the dynamics of the epidemic, and what policies might potentially do. And so, how do you deal with that uncertainty? In some sense, those sort of models, they are quantitative and they do gather as much data and put in as much data as we can at the start, but there are always going to be huge uncertainties about projecting forward. So I decided to come up with a little kind of uncertainty map with two axes. One is are you trying to predict the future, perspective at the bottom on the vertical axis, or are you doing something retrospectively? And one is, are you doing this early in an epidemic, or are you doing it late in an epidemic? And clearly, if you're doing it late and you're retrospectively estimating parameters, you actually generally have relatively little uncertainty. If you're trying to do things early and prospectively, you have an enormous amount of uncertainty. And so early on, we have little data. We use those scraps of data we have. We generally use domain-specific knowledge and knowledge of other similar diseases to make extrapolations, to give our best guesses, frankly, of what will unfold. Late on, we have much more better tools, surveillance platforms, far more data. We can be a lot more reliable, but still predicting the future is incredibly difficult. Step back from from that for a moment, just talk a little bit about science policy interface and the UK approach, which is, we ran a symposium today talking about many of these issues with people from around the world, and the UK has a very specific way of doing these things, which has many pluses and maybe a couple of minuses. But generally, one unique thing about our system is that academic scientists such as myself never talk to ministers. It's incredibly rare for that to happen. All advice goes through committees, those acronyms I'm sure many of you are aware of, through then the Chief Scientific Advisor and the Chief Medical Officer you see pictured there. And so the intent here is of scientific advisors such as myself and of groups such as SAGE is to advise on the likely impacts of different policies, but not to say this is what the government should do. We don't make value judgments about what policy should be adopted. The policy is determined by government, given the assessments of risk and potential impacts of different policies, and the detail is all determined by government. I mean, I've never been in a meeting where we've been asked fine detail about the wording of particular things, which then end up on gov.uk. I've already said multiple academic groups examine each question, and there are therefore many checks and balances. There's lots of discussion of the data and what the interpretations of that data are, which always tend to be several, and that gives a thoroughness to the advisory process, and it means that many of the SAGE consensus statements on the state of science, NERVTAG as well, are quite authoritative documents given the level of uncertainty, but perhaps this is a slower moving process than is sometimes optimal. It's also very dependent on those two critical roles, the Chief Medical Officer and Chief Scientific Advisor, Chris Whittier and Patrick Vallance in this case. And there are tensions, of course. And SAGE has walked either side of this line at various points. Tensions between advising on policy options and recommending particular policies of in some sense, guiding policy, and equally politicians saying they're being guided by the science. What does that phrase actually mean, guided by the science? It doesn't mean being directed by scientists. So SAGE, certainly very early on, before middle of March, was adamantly not advising a particular policy. It was giving information on the likely impact of different policy options. From about mid-March onwards, that did change a little. And again, coming through till, let's say, October last year, late October, it also veered into SAGE being more directive. Frankly, I think out of concern of the level of inaction being seen in government in the face of rising case numbers. Interestingly enough, my view, and it is a criticism, I don't think SAGE or any scientific advisory committee was ever told the government strategic policy, given a strategic policy objective by government. We were never asked, what strategy will minimize economic harm while preventing the NHS being overwhelmed. For instance, I'm not saying that's the question we should have been asked, but it was never a question asked. I should say the answer to that question is not waiting to the last minute to lock down. This plot here shows the relationship between GDP loss on the x-axis and deaths basically in the first wave of the pandemic, and the countries which suffered the highest deaths, locked down later, also suffered the highest economic harm. Talk a little bit about the politics of COVID science and the role of scientists. It's naive to pretend, I think, that scientists stand completely outside politics. We certainly have political views, even if we don't express them. And in a major crisis, the advice we give and the work we do has relevance to everybody's lives. But I still think it's important for scientists to maintain, as much as they can, transparency and objectivity. I mean, so just because infectious disease experts hopefully know more about what's happening in the epidemic and what policies might work, I don't think gives them any fundamentally greater right to determine what should happen. I mean, we are a democratic society where we elect a government to do that, representing a diversity of opinions. What scientists can do is communicate things clearly. And I think in general, some of my colleagues on screen here, that has been done very well in this pandemic. There are exceptions. I think the challenges have come where scientists start expressing opinions, first of all, way outside their domain expertise. I mean, you get some cancer specialists waffling on about infectious diseases when they really have no track record in that area. Scientists expressing policy opinions, which really reflect their individual values and politics more than their scientific background. So government should enact Plan B now. And I should say here, I'm expressing my own personal view of what scientists roll out. There are many of my colleagues and friends who would express a different view, but I still think if you're going to be a kind of even-handed arbiter and trusted by public, one should avoid saying this is what should happen. Also, political perspective has sometimes affected objectivity, only in a limited number of cases, but certainly there are scientists out there who have fundamental beliefs that lockdown was the wrong thing to do, and then therefore, in some cases, have tried to undermine the science which supported suppression type policies. And that brings me on to this thorny topic of diversity of scientific opinions. It's inevitable when data is limited, noisy, not always consistent. Different studies will disagree with each other. There's always going to be uncertainty. There is always plenty of opportunity for very valid scientific debate. And I think it can be unfortunate that sometimes the media present this in a dichotomous way, two camps of opposing scientists. There has been a very, just as there is in climate science, a very small minority of scientists who've taken, let's say, quite left field views, but within the mainstream of the scientific community, there have been disagreements about things, diversity of opinions, even diversity about necessarily what the best thing to do is at a point in time in terms of its likely effectiveness. But it has been a continuum, not a two political camp scenario. I've already said, I think input in reporting this sort of scientific debate, people who are more credible tend to be the domain experts and who are actually doing work on the topic rather than scientists acting as commentators. It's less credible, therefore, from people who don't meet those criteria. And so we did have a problem, for instance, in summer, autumn of last year of a degree of false balance in reporting. You'll remember things like the case-demic being talked about of what was the level of false positives in PCR testing, that somehow the increased case numbers would not translate into increased numbers of hospitalizations, all of which very few people in the mainstream scientific community believed was true or significant factors, but still did take up quite a lot of space in the public narrative for at least a few weeks, if not months. Leads me on to, it has been quite a torrid time to be a scientist working in this area. Many scientists have received a torrent of abuse. We've all actually mostly received very nice emails, letters and things as well from people thanking us for work. I think the attacks on scientists have been principally ideologically driven, in my view. Not to say there is a single ideological mindset out there. I mean, it's been actually many different strands of lockdown skeptics, libertarians, anti-vax groups, and then all the way through to the kind of fringe conspiracy theories. But there've been certain common themes of basically rejecting evidence which is incompatible with those individual groups or individuals' worldview, reliance on rhetoric rather than, in my view, reason, and frankly, searching for someone to blame, which is a typical characteristic of certain sorts of populist politics. And just as in climate scientists, typically picking on a few small number of scientists in each country as bêtes noires, of which I've certainly been one in terms of the anti-lockdown contingent in this country. I think it has improved over the months. It has become less heated than it was, for instance, in September, October of last year, but still has been quite a challenge. Nature published a really quite good investigation of this topic spanning many different countries. And it is not unique to this country. In fact, this country has been rather better than some. My US colleagues have really been through the mill. And sometimes these debates have been blown out of all proportion. I mean, the Swedish model, for instance, often cited by lockdown skeptics, but really the differences in policy options, and we had Anders Tegnell on the symposium I ran today, who's the state epidemiologist in Sweden. They basically adopted a policy which was akin to suppression. They drove the reproduction number below 1, but because of their history, they were able to rely on non-mandatory measures, but basically measures adopted by 95% of the population, much more than many other countries. And so whilst it is certainly a valid topic for ethicists, lawyers and politicians to debate the merits of, of liberty, let's say, versus collective action, it's not one for epidemiologists. We just look at the data and evaluate how effective different interventions have been. In the interest of time, I won't go through this, but we have actually done quite a lot of work evaluating how did Sweden do compared with the UK, compared with other Danish countries. And it comes down to the fact of, if you act early, then you can do quite well. If you use more stringent interventions, such as Denmark did compared with Sweden, you also do a bit better. But it's a combination of both timing and the type of interventions, rather than just a simple thing of lockdown works and other policies won't. I should say, just my final kind of remarks on the kind of political side. I mean, I think the real long-term legacy of this pandemic is going to be the enhanced inequity that it has generated in the world. I mean, basically, the young sacrificed an enormous amount to save the old. It's exacerbated intergenerational inequity. 99% of deaths.
I don't know how anyone can sit through this nonsense. You're a fucking murderer. You're a fucking murderer. These stab vests that are being injected. You're a fucking disgrace.
There is time for questions and answers afterwards.
As I said, 99% of deaths have been in over 40-year-olds. And the 80, if you're over 80, you're 100-fold more likely to die than if you're 40. Ethnic minorities have been disproportionately affected, not just in this country, but in all high-income countries. And people living in deprived areas have been much more likely to die from this pandemic than those in, well, 45% than those living in the most affluent areas. And so, and beyond that, low-income countries have suffered far more than high-income countries. And so this legacy will have to be dealt with in the coming decades. And I'm not sure if everybody realizes quite how long it will take to resolve this legacy. I'll just conclude with a few points on what we've been working on this year. Modeling got a lot more difficult, really from about November of last year onwards, for multiple reasons. First of all, it's relatively easy to model the spread of a new virus in a population with no immunity, but things got more complicated. First of all, as a higher proportion of the population gets infected, you get naturally acquired immunity, which has to be accounted for. We had new variants of the virus come, Alpha, and then this year Delta. And we started vaccinating, and that boosts the immunity of the population. And again, reduces transmission, has to be accounted for in modeling. And so it made prediction even harder, but even though that's quite a small portion of what we do. And with some exceptions, the politics continued, but got a little easier. So how do we, one of the things we spent a lot of time doing this year and last year, the end of part of last year, was characterizing these new variants. One of their characteristics is all pathogens evolve to become more transmissible. There are, of course, limits on how much a pathogen can do that, a new virus. But when a virus is new to the human population, as COVID is, there's lots of scope for that evolution to increase the fitness of the virus, increase its transmissibility. And that's what we saw with Alpha and then with Delta. And you could see this unfolding in real time with the initial spread of the Alpha variant, which almost certainly originated in this country. This is surveillance data, case numbers over time in different areas of England. just focus on the two thin bars at the bottom of each of these. The pink areas are the second lockdown, then the third lockdown. And the thin middle orange bar is the alpha variant rising. And the blue was the virus we had before alpha, the pre-alpha lineages. So that second lockdown, just focusing on that initial area of pink, we saw the old variant declining in case numbers. That lockdown was working, and but the alpha variant was increasing. That lockdown was insufficient because schools were open to actually contain its spread. And from analysis of that sort of data, you can estimate roughly a 50 to 80% increased transmissibility of that virus. There was other data suggesting it was also perhaps more severe. And we repeated that similar sorts of data with Delta in red here and Alpha in blue this year with the emergence of the Delta variant, which didn't originate here, it originated in India and was imported. But again, we saw in a period of time where vaccination was working, we were relaxing lockdown measures, that would have been plenty sufficient to keep Alpha suppressed. We wouldn't be seeing the wave of transmission we have now if it had just been Alpha, but Delta was again 40 to 80% more transmissible, and so we saw case numbers go up. The solution has been vaccines, which have really transformed this pandemic this year, with now 90% coverage in most high-risk age groups. And we've been doing a lot of work characterizing, along with colleagues in Public Health England, how effective these vaccines are at protecting against death, against hospitalization, and against just mild symptomatic disease, against the Delta variant. And what we're seeing is, this is for the two different vaccines, mostly in use in the UK, we're seeing very high levels of sustained protection against death, in excess of 90%, even with a degree of waning. We're seeing protection against hospitalization, against severe COVID disease, still staying up, but waning a little bit more, particularly for the AstraZeneca vaccine, which is why booster doses are being accelerated at the current time. But the real challenge has been for the Delta variant that the protection just against infection, against mild disease, and therefore against people who are vaccinated, spreading the virus to others, is much lower, particularly for the AstraZeneca vaccine, and has been declining the fastest the longer you get away from when you had your second dose. And that has been the challenge that this country has been facing, and other countries, Israel, some European countries have been facing as we go into the autumn, that we've been very successful in getting vaccine into the population. We have saved a lot of lives by doing so, but now we're seeing quite high levels of transmission. We've been doing work all year to look at this balance of contact rates in the population, of immunity in the population, how much you can relax restrictions with real-time modeling. And I won't, in the interest of time, go into too much of the detail of this, but this is just an illustration. Again, none of these scenarios came to pass because, of course, the government did something different, but we did lots of work looking at, as you vaccinate the population, that will protect them, it will reduce transmission, so you can safely lift restrictions at a certain rate. And the aim here was to inform how quickly could the government lift the third lockdown restrictions which were put in place in January this year. And so the results of both the modelling we did, London School and Warwick didn't define policy, but informed policymakers as to what was likely to be a viable strategy. We're doing similar work looking forward now. And here, maybe the only thing that these are lots of different scenarios, and I throw it up not to go through each one, but to highlight the fact that at any point in time, even right now, there's an enormous amount of uncertainty about certain parameters. The blue curves compared with the red curves represent the effect of delaying that last step of the roadmap. Remember, we were meant to have Freedom Day initially, I think on the 17th of June. That was delayed 1 month to July because of the rise of the Delta variant. And we project that that probably did have really quite a significant effect in reducing infection or keeping infection levels at a sustainable level in terms of the NHS. Booster doses are not included in this, and the latest modelling we've done suggests that boosters, as they get rolled out in the population, will have a dramatic effect on transmission if the uptake is high enough. And so hopefully we should be seeing declining case numbers towards the end of this year. So where next for the UK? We've had a few weeks of slowly increasing hospitalizations and deaths and case numbers, now plateaued though, but it's a little too early to say whether this is the beginning of the end, as it were. The case numbers are going to consistently come down because of the effect of boosters, or whether it's just a half-term effect because children are away from school, testing patterns were different. We will have to wait another week or so, but still, as I said, the later stage modeling would suggest boosters are going to have a significant impact. So just to sum up, in conclusion, there are 5 million reported, virologically lab confirmed deaths from COVID worldwide so far. Probably of the order of twice that, given the limited access to testing in many countries of the world. But nevertheless, despite that toll, the unprecedented policy response to this pandemic has saved many-fold more lives. I think if I look back to where we were at the beginning of last year, the thing which would have made the biggest difference is having more testing capacity in place, both in this country and globally. It was inadequate and it was misdirected. It was directed at borders rather than setting up a systematic surveillance system in our countries. Small differences in the timing of lockdown across European countries, at least, made a large difference, had a large impact in terms of explaining the different death tolls seen in different countries across the world. Science clearly has been caught up in quite a polarized political debate around managing this pandemic. So whilst the modeling done in March of last year said we would need to repeatedly lock down, it was only basically when hospitals started filling up again in London and other areas that politicians acted, both in this country and same was true in multiple countries across Europe. Not all, but a lot. And that means that 2/3 of the deaths which the UK has experienced in this pandemic happened after 1st of November last year. Now, part of that is definitely down to Alpha, and this is another lesson that the importance of genetic surveillance, which the UK has been world leading in. There's been, and I don't have time to go into the details, but we all know this, a lack of international political coordination in terms of policy responses, probably best seen in terms of vaccine-related nationalism. But put against that, there's been really unprecedented scientific openness and collaboration across the world. I think analysis and modeling has played an important role in giving us understanding of what we're experiencing and informing policy response. And just to conclude, as I say, I think we will be dealing with the legacy of this pandemic for many years to come. And I think a priority is to deal with the fact that it has exacerbated inequity and inequality in our societies. Thank you.
Thank you very much, Neil. And now we've got 57 participants online. And so we want to make sure that the online participants also have a chance to ask questions. The Sowerby lectures have always been controversial. I can see quite a number of you who want to make statements probably rather than questions. If you want to make a statement, please put your hand down. If you have a genuine question, I will certainly turn to you, but it's about listening to each other, not attacking each other, but actually genuinely listening and thinking together about the issues that Professor Ferguson has raised. So first, let's just check what we've got in terms of messages. And could we just put in that we can take questions now from online as well as from the audience there. So if I turn first to the lady here, and we'll take a few questions together, and then you can answer them, Neil. Hold on, I think we need a microphone. And would you give your name, please?
of your models of the pandemic has been the most accurate or least accurate? How do you explain the errors your team made about swine flu, BSE, foot and mouth, bird flu, and COVID-19?
And let's take one other question, then we can turn to that. We've got a question at the gentleman in the middle there. Yeah, the gentleman here. Mhm. Yeah, with the red top. No, we have many questions. There's several in the back. I'm going to try to spread it out. Yeah.
I know before that you said that everything is totally outstanding. But I suppose it's just like your personal views on like how to COVID.
Could you speak into the microphone? So a question on errors, not just in COVID modeling, but in other modeling, and a question on your own views on inequities across generational divides. And while we're listening, you can put your hands down and I will come to other questions afterwards.
So in terms of accuracy of modeling, and let's focus on COVID, because I think you're probably repeating things which have been in various articles which are inaccurate in terms of the other models. COVID modeling, as I say, retrospective analytical modeling of trends which have happened in the past is always going to be more accurate than scenario modeling of counterfactual scenarios where you can't precisely predict what policy will be and what people's behavior will be in the future. So undoubtedly we have got better as the pandemic has unfolded, just because our knowledge and our quality of data going into the models has improved over time, but it's still a very imperfect business. I mean, I cannot say at the moment, for instance, we cannot predict definitively whether case numbers will bounce back up again next week and continue to increase for a few weeks, or will continue on a decline. And that just reflects not really the quality of modeling, just the level of uncertainty in input parameters and things we just don't know precisely enough to quantify, and the challenges of measuring human behavior and contact patterns. To the kind of personal issue, I mean, I should say, I think the policies which were adopted ended up being adopted not because I, Boris Johnson, or anybody else were immediately reaching for lockdown measures, because everybody on SAGE recognized the enormous economic and social costs of lockdown. They ended up being adopted more than anything because of the increasing evidence that the NHS was about to be overwhelmed. And if you let your healthcare system fall over in the same way as did happen early this year in places like India, like in Mexico, in some areas of Brazil, then that has massive knock-on consequences. And it was felt to be just politically unacceptable by the government to allow that to happen. And undoubtedly, I'm very conscious of how this pandemic and the measures adopted have increased inequity. I mean, that's why I put it on the slides here. And personally, I would like to see that be a political priority to address that going forward.
Thank you very much. And I know there are quite a number of other questions. So we'll take a question from the lady there and a question from the gentleman there, and then we'll come down to the row here. I know you're very eager to. Those two, one after the other, the lady first in the green, and then the gentleman in the red.
Hi, thank you very much for your talk. So most of the data that has been focused on within the pandemic has been focused on the link between mortality and catching COVID. But since the pandemic has started, we have noticed that there are other factors at play, such as those getting long-term COVID and those who will have to live with the consequences of catching COVID for the rest of their lives, essentially developing chronic illnesses and so forth. So I was wondering how that would impact on your studies going forward, and also maybe future studies of future pandemics and so forth.
If you pass it down, we'll take a few questions together.
Good evening, Professor. My name's Victor. I have a terrible confession to make. I didn't realise that the USA was a low-income country, having heard it tonight for the first time, that low-income countries were most affected by the coronavirus scare. So if you can forgive my ignorance, and it may underline my question that I do want to ask, that is this. As a fairly old, albeit ignorant person, I remember at least 3 medical scares this century. First, there was Chinese bird flu. Then there was SARS. And now we have the coronavirus, all of which we're told came from the same one country. What are the statistical chances of something like that happening in a century that's barely 21 years old? Thank you.
So,
Okay, so
which one do you want to take first?
I will deal with both of them. So long COVID, so I have not, my group hasn't been studying it, but certainly within Imperial and more broadly in the epidemiology community is increasingly studied. Data on it is still, unfortunately, somewhat limited, but there are some good cohort studies underway, and I certainly accept it is potentially going to be a legacy of this pandemic we have to deal with for many years. I'm just not an expert on it. On the second point, first of all, I didn't say the US was a low-income country. What I was trying to compare was the countries which have been worst affected. I think you're referring to this in terms of mortality, or the areas of countries and worst affected economically tend to correlate. So places which locked down later had a higher death toll, also had a higher economic impact. But in terms of the overall impact, if you compare countries across the world, the economic impact of the pandemic has been worse in low-income countries than high-income countries. So the US has suffered about the same as the UK, much less than, for instance, the poorest countries in the world. Coming on to China, well, I mean, SARS was a very serious threat, but thankfully it was a threat which was contained. We could talk about why that was contained, but it was a huge effort. As to the chance that, for instance, SARS-1 and SARS-2 came from China, China has 1/5 of the world's population, often living in close proximity to wildlife populations, and most likely hypothesis, not the only hypothesis, most likely hypothesis for the emergence of COVID is spillover from a wildlife species. And when you get very high large populations, very high population density, that becomes more likely.
Thank you. Now there's a suite of questions. I'll come down, we'll start up there, then we'll come to you, and then we'll come to the gentleman there. So we'll start there, then you, and then we'll finish there. We'll take a group of 3.
Thank you very much. Jim O'Brien from Denver. It's marvelous talk, and as a critical care physician, I have to tell you that I sympathize maybe from a different perspective, more of a grassroots perspective, but it's been a very difficult time, I know. But my question is, do you have an opinion on the origin of the virus based on information now that is coming out that suggests that it may be an escape virus from the high-grade viral lab that was in Wuhan near the market? And if that was the case, would that have changed your modeling?
So interesting question. I think it's statistically more likely to have been most likely an import from an animal reservoir, but I would agree with the recent US report that we can't rule out an accidental lab release. Would it have changed the modeling? No, not really. I mean, fundamentally, the modeling was being driven by the data coming out of Wuhan by the time it had escaped and there was an outbreak taking off. And I should say, I'm not a virologist and I'm not an evolutionary biologist of, geneticist of viruses, so I'm not the best person to comment on whether there's any signature of anything in the virus itself. I mean, it's quite distant from most other clades of coronaviruses in both animal and human species.
Thank you. So we've got one question here, and then we'll take the last question there, and we have the vote of thanks.
Can you hear me? Yes. First of all, I've got a two-part question. Texas, many months ago, took away masks and they took away social distancing, and there's no vax passports, and they took away all the rules, and the case numbers have continued to go down and down and down. And secondly, from a personal point of view, should you personally, as you broke lockdown rules, should you back away from this, stop going on the BBC, stop going on any channels and talking about it, as you broke lockdown rules and you support lockdown?
Just one sec. Did I understand that you're going to close the discussion down after the next questions? Did I understand that that's fine, but did I understand you're going to close it down after that? Is that correct? I'm happy to pass it.
I mean, I'll take another couple of questions. Maybe I'll just address, I mean, US has seen a diversity of trajectories. Both Florida and Texas saw a surge of case numbers with Delta and in the last few months, and then a decline thereafter. The Texas actually achieved a rather higher vaccination coverage than some US states, but they also experienced quite a large epidemic. So I don't think you can generalize from one location to another, or certainly pick out an individual location. If you look at the overall impact of the pandemic across US states, then it has been, well, the US is now up to in excess of 600,000 deaths, which is not that far off the 1 million which we projected for just frankly a plain mitigation scenario of them not locking down at all. So I mean, the US has really suffered, quite immensely, and that has varied from state to state during this pandemic. I mean, I understand the point you were making, but I'm not going to be drawn into it. As to, I mean, I get invited on the media. I have apologized for my own breaking of lockdown rules many times, and I think that's all I have to say on the issue.
Thank you, Neil. If you're taking a few more questions, there are a few questions online. Do morals and ethics influence your work in modeling? And then you suggest that epidemiological modelers should keep their modeling separate from their personal views and should not intervene to recommend particular public policies. Do you think this holds true, even when cases are doubling rapidly?
Well, maybe I'll take the last of those. I think, as you said, I think SAGE has walked that line, or both sides of that line. I think where it has got closest to crossing that line has been in the case of rapidly doubling case numbers and a real concern about healthcare demand and the mortality which will ensue from that. I still think it is better to explain the consequences of different policy options than to necessarily advocate them within the public arena. I mean, discussions which happen in private with civil servants, and it tends to be civil servants or people like Patrick Vallance and Chris Whitty, tend to be rather more open. But even there, scientists try to avoid just expressing their own personal political views.
I can see you're about to do a poster and put up a poster. No, but I can also see you unfolding a poster. We are trying to have a genuine conversation here. There's a medical student who...
Somebody who's responsible for the deaths of thousands of people. Midazolam, prescribing, how did that affect the figures in April 2020?
If
I wanted to ask a question, how can you...
I'm actually trying to make sure that the gentleman here who has a question, and then you, and we agreed that you could ask the last question, okay? But I also see that you want to do a protest, and I'd ask that you not do that.
My hand's been up all the time.
There are lots of people that have.
So we're going to let this young medical student ask a question, and then we will ask you to ask the last question. I realise that you can decide between the two of you which one you'd like to do. Now listen, please.
Thank you very much, Professor, for the wonderful lecture this evening. The question I had is, where do you think we are in terms of COVID being endemic? We've heard the phrase living with COVID quite a lot recently. And as we know, when transmission is sustained, the case numbers increase, there's a higher probability of new variants emerging, which could obviously have a devastating impact, not only all the countries who have vaccinated their populations, but also the low and middle income countries where vaccine coverage isn't so high.
So it's a very good question. I mean, the transition to endemicity is not an easy one to define, but I think a working definition is that we're not seeing explosive epidemics in the absence of restrictions. And so at the moment, we're not quite there. And if you'd like me, let me finish the answer. So at the moment, we are not at what you could call herd immunity. I think what we'll see is 2 or 3 years of still getting significant excess mortality, not anything on the scale we've had before from this virus. And immunity building up in the population through exposure, through repeat vaccination. And eventually it will become a virus which I think will be with us and will cause deaths every year. I mean, a bit like new flu pandemic viruses are, but I don't think will require the sorts of exceptional measures we've adopted in the past. What it might require, which may not be a bad thing, is some increase in healthcare capacity in this country, because we have the smallest number of hospital beds per capita of any large European country.
So you have one question here, and then we'll take one last question from Robert Northcote online. Excuse me, we've agreed one last question from the gentleman here and one last question from online.
I just want to say a couple of points. You're a professor of epidemiology, and yet you made a statement, there is no immunity. How could 80% of the population recover easily and large numbers of people be asymptomatic if there's no immunity? It's quite clear from studies all around the world that there was prior immunity, cross-immunity from other coronaviruses, and T-cell immunity, which means that is why most people recovered adequately. Immunity does not mean you don't get a disease. Immunity means you can fight it off. Unfortunately, our professor doesn't understand that. I can't understand why he's in charge of such an important role if he doesn't understand that. SARS, according to the World Health Organization, SARS disappeared in 2004 or 3.
We asked you to ask a question.
I'm asking a question. I'm being very quick about it. Oh, come on, let me do it. I'll be done with it in a couple of minutes.
I mean,
I'll be done in a couple of minutes. Is it a problem?
Yes, it is a problem.
Is it a problem?
I mean, let me respond to on the issue.
Just quick. I'll be very quick.
30 seconds.
Fast, Mike. You can understand these questions. The SARS virus never disappeared, according to Zhong Nanshan, that's the lead epidemiologist in China. He made a study published on Cornell University website in 2013 showing that children in Guangzhou had 20% prevalence of SARS antibodies born after 2005, studied between 2010 and 12. So SARS never disappeared. Third, the geography, I can speak just as loud.
Is almost entirely in care homes and hospitals. The policies imposed by the government and governments around the world led to large numbers of deaths in care homes and hospitals.
That's the primary geographical concentration.
Thank you.
One final point, and then just a quotation, and that will be it, okay? One final point for the quotation. According to the BBC, a couple of days ago, 50% of children have already had a coronavirus infection. Given that that's the case, why are you vaccinating children who've already got prior immunity? Do you not believe anymore that prior immunity from an actual infection is more powerful than immunity through vaccination? One final statement. That'll be it. One final statement. I read from John Ioannidis. His article, Forecasting COVID-19 Has Failed, which concentrates entirely on Neil Ferguson's statements.
It says, on reviewing your predictions, John Ioannidis from Stanford University states, quote, implausible, exaggerated forecasts should be abandoned. Otherwise, they may cause more harm than the virus itself. With COVID-19, espoused wrong predictions can devastate billions of people in terms of economy, health, societal turmoil at large. Isolating infectious impact from all other health, economic, and social impacts is dangerously narrow-minded. More importantly, with epidemics easy to detect, opportunities for declaring global emergencies will escalate. Erroneous models can become powerful, recurrent disruptors of life on this planet. Civilization is threatened by an epidemic of incidentalomas. I'm sure you've read this article. Is there anything in these statements that does not apply to your predictions of your teams? Do you not accept that the continued use of your model puts humanity at risk?
Children are more likely to die from the jab than catching COVID itself. So will you call for the ending of the jabbing program of children? Would you want to kill more?
Would you please
I
sit
don't-
down?
Would you like to
Please
say
sit
something
down
about
and
kids'
allow the
vaccinations
speaker
or not?
to respond in an academic way. And then we will have the vote of thanks.
I mean, there were multiple things raised here. I'm not going to respond to all of them. I mean, there is an interesting question about prior immunity and T-cell immunity moderating severity of disease, but there is no evidence that it blocks infection, and there was no way of. And so I think if you actually talked it, well, I mean, you might ask the question, how is it that, you know, in excess, if you talk about Amazonas in Brazil, then something in excess of 60% of the population got COVID in that state. Even in this country, at this point, something like 30% of the population has been infected. I mean, I hear you, but when I talk about people, you know, rejecting evidence inconsistent with their view, you're picking a tiny handful of examples.
This is a chance for Professor Ferguson to reply to the questions that he's been given, and then actually we might have to conclude very quickly.
And then in terms of childhood vaccination and vaccination of teenagers, I mean, first of all, it is wrong to say that vaccine is more harmful than the infection. Yes, the risks of infection are low in teenagers, but they're still higher than posed by the vaccine. And
this is a chance for you to hear the reply.
and 70
Article, the children are dropping dead at school, cardiac arrest. I can't remember that happened when I was a child.
Can you just please?
How can you say
I'm afraid we're going to have to.
How is that not from the vaccine? What weird coincidence? It's not a rare, it's not a rare, it's not a side effect, it's an injury.
Well, what did the JCVI recommend for vaccine children? The government still went ahead. Can you explain that?
There's a zero chance of them dying, literally.
Explain the science of them. No, they're following the science, aren't they?
I'm
following the science.
I don't think actually you're listening to the science, so I think we should maybe record.
So,
So if I could just ask everyone to be quiet for a moment. We've just demonstrated what Professor Ferguson has been talking about in his lecture. Had we staged this, we could not have done a better demonstration of the challenges that we face. So I'd like to say thank you to Professor Ferguson.
Fine. I think they're sort of demonstrating.
And they stopped the discussion, as they stopped all discussion across the world for a year and a half. No more lockdown!
I think maybe
Resist! Comply! Do not comply! Resist! Comply! Do not comply! Resist!
There is an option of grabbing a drink, or we might just move on.
I invite you, Neil Ferguson, to come to Speaker's Corner on Sunday and debate with me. We will protect you. We will make sure you're free to discuss openly and clearly with the police present there. Are you prepared to come to Speaker's Corner and debate me? I'm a doctor from King's College. Are you prepared to discuss? I'm a doctor from King's College. I'm a doctor from King's College.
So we have had a lecture by Neil Ferguson. He had 45 minutes to speak. We have had a Q&A, and different people in the audience have had to speak. You in particular have now had 10 minutes to speak. I have been counting. So I ask you, and we have the room until 8. So I ask you to just, for the last 3 minutes, let Richard Trember speak. He will wrap up, and thereafter you're all welcome to join us for a drink. Richard.
Suffice to say, and if I may, I just wanted to conclude a couple of thank yous. I wanted to thank in particular Professor Kingsmill for putting on not only this evening and hosting this evening's lecture, which is in the context of quite rightly driving discussion and debate, but it has been preceded by a workshop, as she alluded to, over the last 48 hours, which has added to and enabled that further debate about the intersection of philosophy and medicine. I absolutely want to recognize, and if I may, thank the Salisbury Foundation for their support that enables us to create a forum such as this for discussion and debate. I actually want to thank you as an audience, both those here present, but those who have been online, who have engaged in the discussion and indeed enabled us to hold this evening's lecture. And so can I finally thank Professor Ferguson for joining us this evening, sharing his understanding and indeed the science that he has supported and developed, and has allowed the philosophical discussions, some of which, of course, we've engaged in this evening, and I might say, form the basis of the essay that we celebrated as the Sowerby Prize as well. So with that, if any of you feel able and wish to, there are refreshments in the foyer, and thank you again most sincerely for joining us this evening. Thank you.